work as professionals. And this session 3, which should have started at 2 p.m., if you look at your clock now, we are actually at 4 p.m., which is 2 hours late. And this are several sub-themes, and one is positioning health as a national agenda in Kenya for attainment of UHC. And so our first presenter this afternoon will be Dr. Daniel Moi from University of Nairobi. I would like to know whether he has been put on. You'll be presenting this virtually, and this should take us at least 15 minutes. And so the IT team, if we could get Dr. Daniel Moi on, who will be speaking to us on the role of advocacy in improving health financing. Is he on? No. Can I have Dr. Mathew Thuku? Yes, please. Dr. Mathew Thuku from NHIF. Mr. Isaac Ntwiga from AMREF. Isaac, please. Where are you? Isaac. Mr. Isaac, can I see you? All right. Mr. Irungu Houghton, please, if you can come in front, please. I think maybe you can be setting the shrine for Dr. Mathew Thuku so that we get on moving. Then followed by Irungu. Dr. Peter Kamunyu, are you around? NHIF, please. Dr. Peter Kamunyu. All right. So, the IT, by any chance, is Daniel Moi available? Anything? Is available? No. All right. So, ladies and gentlemen, allow me to bring in Dr. Mathew Thuku from NHIF, who will be speaking to us on the view of industrial actions in Kenya, the frequencies, issues raised, and the employer response and their settlement. Please, let's put our hands together and welcome Dr. Mathew.
Yes, good afternoon, everyone. My name is Mathew Thuku, and whenever I'm in a conference of health workers, they baptize me doctor, like what I've just been called. And I think I'm becoming a doctor very soon because the society has decided. So I'm a HR practitioner, a nurse by practice. And I've been working in this sector for a number of years, having worked with the unions, most of them seeing them form, and also provided capacity building through courtesy of IntraHealth, Strathmore Business School, under the USID funding. So I'm hoping the slides will load.
Your slides are not here?
They are there. with the Wilson. Anyway, before he can put up the slide, we can still discuss this subject. And when we talk about the view of the health workers' industrial action, it is not a new phenomena within the new constitution, but it was there even in the 80s. The only thing is that it escalated more between the year 2011 up to currently. I know even as we talk, if you scan around the counties like Taita Taveta, you might find some workers who are on strike over one reason or the other. And mainly the grievances have been more or less the same, meaning that for over a period of over 10 years, the issues that arose during devolution have not fully been addressed. And that actually put us to task in terms of just checking in terms of how best can we be able to address the health workers' industrial relations or employee relations so that industrial action become something that is not regular and something that can be managed. So I know within the Constitution of Kenya, Article 41, it has provided for the rights to go for industrial action for health workers. But it also has some limitation of that right under the Bill of Rights, which put the right to life above the supreme right, where all the other rights are enjoyed after you have the right to life. So it's not absolute. And true, there is also another article within the same, which is 41(2)(b), which also relates to the issues about the right of one individual should not override the rights of others. So as we look at the context of industrial action, we also look at the context of what is the right of the patient as we also undertake industrial action. I think the slides have at long last come. So that is the overview. I know I've almost covered this, right? So historically, if you look at if you are reviewing the industrial action in Kenya, if we look back from 2011, we have had industrial action almost every year. And the ones which I've listed here are major strikes that have national scale, not the one which happens in each county. And you see that up to around 654 days between those years have been consumed on strikes. If you were to compute that in terms of lost man hours, based on the number of health workers on strike, their salary, you see the amount of money that actually these strikes drain. And this was not left out during the COVID period. We had strikes between December 8th, 2020, up to around March of 2021, where the clinical officers had 76 days of strike, the nurses 91, and the doctors had 19, and the laboratory technicians joined in and had around 13 days. So there has been also days where there has been period, especially between 2016 and 2017, December 2016 to around March 2017, there was around 100 days of the doctor strike. Then June 5th up to around November, the nurses picked up and went for around 152 days. And those are among the longest strikes that have been held in the country. So when we look at the issues that the health workers raise, as far as the strikes are concerned, most of them have a similar pattern. Mainly the issues of terms and conditions of service. That is about the remuneration, the allowances, and the working conditions. The others are around the issues about promotions, stagnation in promotions, and this was quite common after devolution, where a number of health workers had stagnated in one position for quite a long time. And I think through this, a number of counties have been able to implement some level of promotion. Then there have been issues around CBA. The 2017 strikes were revolving about the either signing of the CBA for the doctors' union and the negotiation of CBA for the nurses and the clinical officers. But we know in the history of industrial action in Kenya, the only CBA that has actually been never signed is the doctors' one. I think it should be expiring at the moment. The others, nurses and clinical officers, their CBAs have not been signed unless I'm not current in my information. But there were return to work formulas that were discussed, and some of them led to some level of increment in allowances. For example, the nursing allowance that was offered in 2017, and that also led to the other 17 cadres also going on strike, demanding something similar. And I think that is when an allowance which was called the health service allowance was brought into the fold. There was also the issues of the job evaluation that was carried out by the Salaries and Enumeration Commission, which basically the nurses, the clinical officers, and most of the health workers felt it was not done in a justifiable manner because it had put them at grades which were relatively lower, sometimes almost in comparison to the staff who are not technical or even to the level of even a driver. For the COVID period, there were health industrial action allowed the medical cover for health workers, the frontline health workers, the provisions of personal protective equipment, the risk allowance, the recruitment of additional health workers, delayed salaries. There was this COVID surge, casuals or contract workers that were hired, but despite them being the frontline soldiers, I think the salaries were also delayed. And that caused the other health workers to empathize with them. There was issues of isolation facilities for the health workers when those who got COVID, and we are told there are over 10,000 health workers who actually contracted COVID, and a number died. From the last time I checked was around 53, and those are only the numbers that may be known. Then the training on COVID, which was also required for the health workers to be able to protect themselves. So those are some of the grievances that have been common within causing health workers strikes. And when you look at on the other side of service delivery, there has been implication, especially in terms of service disruption. I remember within the Daily Nation of November 27, 2017, and that was the year which had over almost close to 300 days of strikes. The Cabinet Secretary then, Dr. Christopher Mairu, actually looked at the year as having very major challenges in the sector, which actually disrupted service delivery. And within that year, over 500 newborn babies missed vaccination. They were allowed increase in the mothers who died while giving birth. There were also missed opportunities for the fourth ANC at a rate of around 28 to 56%. And there were also decreases in viral load testing. There was also reduction in short and long-term family planning method uptake, and also a reduction in deliveries at the facilities, as well as opportunities for admission in about 13 facilities that were surveyed. So there was quite some remarkable changes in service provision. If you look at that, you can see the impact of the nurses' strike in terms of the provision of PMTC services at ANC, as well as the pregnant mothers who are completing fourth ANC visit. It went down in the public facilities and increased slightly in FBO and the private facilities, meaning that not all those who require the service could afford to actually take it up in FBO or in the private facilities. So, if you look at the landscape as far as addressing the health workers' industrial action in the country is concerned, it is bogged down by quite a couple of challenges, some of them being legal, as I initiated. the Constitution has provisions for allowing strikes, and there are also limitations. The Labor Relations Act, which is older than the Constitution, consider health services as essential, and under Section 78, it actually discourages health workers' industrial action. And also, we know that the courts have made rulings calling most of the strike as illegal. And there has been instances the unions who have called for the strikes have not adhered to those declarations by the courts. And we know even some of our union leaders have ever been taken into courts. I know the KMPDU leaders know this very well. And this was just because the way that our country handles industrial action is mostly reactive. We have not had a very proactive way of addressing them. And most of the time, it is more or less seen like more like a context between government and the unions. And I think that doesn't augur well in terms of creating an enabling environment for provision of health services and amicable resolution of the strikes. Then the dispute resolution mechanism is also not very well aligned. You remember there was a time religious leaders at the level of bishops had to come in to try to quell the strike. The president, the Law Society of Kenya. So it's not a framework that is known who is going to address it, although within our framework it's supposed to be the Ministry of Labor, the Ministry of Health, and the other stakeholders like the Council of Governors. But you find that there are multiple players that come in, and most of the time the dispute take longer to be resolved. There is also low trust, because in most cases the government is quick to sign the return to work formula, and I think they almost assume that the health workers will forget that they were promised something, and when they go back to work, those commitments are not met. So it actually degenerates to another industrial action. Then there are also the issues of salaries, which are harmonized by the Salaries and Enumeration Commission vis-a-vis CBAs. The CBAs are negotiated separately from the Salaries and Enumeration Commission structure. And so you wonder which is supposed to supersede the other. And I think that is why, for quite some time, SRC has not been able to sanction the approval of the CBAs, especially for the nurses and the clinical officers. The multiplicity of unions within the same sector. Initially, there were 3 major unions, starting with the doctors' union, nurses, then clinical officers. There are quite a number of others that have come in within the other cadres. And so it's like each cadre is actually fighting for their rights on their own. And that creates a situation where any demand that is made for one cadre becomes a spillover for the other. So you can actually have a spill effect of strike over a period. Then communicating grievances. For example, when the nurses were actually granted a nurses allowance, the other cadres went on strike on the basis that they were not aware that a health service allowance was also being worked on. And also, when you look at the period between July up to September every year, there is always some level of industrial action based on the issues allowed, delays of salaries. Yet we know that we can actually, we can be able to actually communicate to health workers if there are challenges in disbursement from the national government to the counties, or even adequately planned, because a salary is something that is known. It should be paid at the end of the month. So when you delay health workers' salary, I don't think over a 10 years period you have a good justification as to why the period between July and September, the salaries has to be delayed. The other thing that we need to look at is what has been some of the outcomes of this industrial action in terms of employers' response and their settlement. As I stated earlier, the settlement has never been very harmonious or very voluntary. It's always like it is forced. But I can say there has actually been some some positives that we can discuss. One is improvement of terms and conditions of service. The doctor CBA did improve the terms for the doctors. The nurses return to work formula that cascaded also to other health workers, including the CEOs, the return to work formula. If you compare the terms in 2011 to now, there's some increment or there's some improvement, not to the standard that the health workers would reach, but I think we can call, we can actually be able to call a positive where it has arisen, although it is through struggle. It is not money that has been issued in very harmonious or very voluntary manner. There has also been capacity building for healthcare workers as well as the union leaders. And this is on the labor relations mechanism through the International Labor Organization conventions, where you look at industrial relations as a tripartite kind of arrangement between the employer, the employee, and the union. And so you look at more amicable ways of resolving industrial dispute instead of always going on strike and actually having the patients having to suffer. We also have HIH units that have actually been initiated. And this allows as a demand that health workers need to be managed also better by qualified HR practitioners who would be able to address their grievances. There are over 45 counties that have established the HIH unit with around 189 qualified practitioners. There has been a dialogue platform referred to as the Work Council in a number of counties. I've seen Oditi from Migori, who is one of the leaders of the Work Council. I know it also happens in Turkana. And this has helped to come up with dialogue between the health leaders and the health workers union leaders at the county level so that you can resolve dispute early. Then recognition and participation of sector union leaders in HIH forums. Initially, union leaders were seen as adversaries, but now they are being accommodated on the decision-making tables as well as where discussions are done. And I know during the COVID period, they were actually part of the HIH committee that was organizing on the COVID-19 surge response as well as development of the protocol for staffing health facilities on COVID. Then Wage Bill Conference discussed the health workers' industrial relations and came up with the modalities of how the industrial relations should not be looked at a negative way, but we should look at the economic impact of when we actually ensure that we are managing the health workers appropriately. The strategic plan for Kenya 2014-2018, that is the HIH strategic plan, and 2019-2023 also has aspect to do with how to manage health workers' strike harmoniously. So that takes me to the last slide, and the caption there is from one of the health leaders who actually was disappointed that their grievances were not being addressed, yet they were risking their life during COVID, and actually thought that they are better off with their families at home rather than risking their life. Thank you very much.
Hello, yeah. Thanks. So we'll just continue on to the next speaker. Please put on his slide. We have Isaac. No. No. Okay, Irungu. Yes, yeah, Irungu. Isaac, are you around? Okay. Let's have Irungu talking to us about industrial action. You have 15 minutes. Thank you. Welcome.
Thank you very much. Comrades power! Comrades power! Okay. So Dr. Thuku started by saying that he's not a medical practitioner nor a doctor. Let me just baptize myself by saying Nurse Irungu Houghton, or nurse, or rather mortician, Irungu Houghton, just so that we cover the other professions that are here. Good afternoon. Great. Okay. So on behalf of Amnesty International Kenya, a membership movement of about 10 million supporters all over the world, I greet you very warmly. I honor the work that you do in terms of the right to health, and I do not think we have a nation without the courage of each of you individually and collectively. So let me start by just acknowledging this way. My history with the Health Workers Association personally goes back, of course, to when I was born, because I would not be here without some of you. But more recently, I was part of the campaign support for the Lipa Kama Tenda strike, the one that was referenced here. Between 2020, Amnesty provided support to health workers to make sure that you were not clobbered by police officers as you went about providing essential services. We also rose with you several times to speak about coronapreneurs and those that sought to make money out of a pandemic rather than to provide services, masks, and essential protective personal equipment for you all and for those of us that did your services over this period. I was also one of the people that was shuttling between bishops on some of those late nights as the MPDU came to a point of agreement with the government, and in many ways still watch that space with a bit of nostalgia. But let me start by just perhaps broadening the conversation from the right to strike to the right to collective bargaining and the power of collective bargaining. Because I think collective bargaining is a much more powerful framework to have this conversation rather than narrowing in on essentially what is the tactic of last resort, which is the right to strike. As I watched Dr. Thuku's comments, rather presentation there, and I enjoyed it very much. Thank you, Bwana Thuku, for that. I was struck a little bit by if we were in France right now, the common joke in France when the health workers talk to each other, they often say, what do you call that break in between strikes? And the French will always respond by saying it's called lunch. I think we have to start off by acknowledging that although there has been a propensity to go on strike, the reality is that that is not the only form of collective bargaining and collective action that was taken. But having said that, I think we have to start off by acknowledging that there are few examples of transformative action that have changed the working conditions of our health workers in this republic without the threat or the action of withholding labor. A few weeks ago, Dr. Odhiambo Olel, one of our elders, one of our national leaders, died after several years of action for the rights of workers and also for the right to health. And Dr. Olel was involved in, I think, one of the very first strikes. And if you get a moment to just look at his interview on YouTube, he will tell you that it was really a risky behavior to go on strike back in the 1960s. Now, of course, with the new constitution, with Article 41, this strike is constitutionally protected, and you have the right to be protected while withholding your labor. But I think, as we've seen from the presentation that was made by Mathew Thuku, I have to stop saying doctor, otherwise it's really going to stick. Huh? You'll go home, and your family will say you've been very busy today. Strikes come at great cost, and I think we've seen that. You have facilities, but you do not have capacities. You do not have healthcare professionals to be able to provide that. And what happens is people get more sick, and in some cases, as we saw, particularly in 2017, people die. You also see dysfunctionality in the sense that employers begin to draft unskilled personnel who take over your jobs. And for that, with that also, you see dysfunctionality, and of course, many people do not get the kind of quality treatment that they require. More importantly and significantly, you also see the erosion of the health gains that we as a nation are trying to generate. And therefore, you see growing numbers of people falling back on our constitutional promise. The last one, of course, I think is that both you as health workers individually and also collectively, you feel the weight of a reducing public confidence and a trust in you as essential workers and also in your profession as a profession that cares. And I think these four impacts are really the things that we have to weigh every time we think about going on strike. But let me turn perhaps to a couple of other bigger ideas that I think are useful to keep in mind at this moment. The first is the inequalities that we have in this country have killed more people than the miserable virus that we call COVID-19. What we saw over the last 2 years is that if you were powerful enough, if you were wealthy enough, if you were privileged enough, the kind of services that you got would be very different from the everyday citizens that didn't have these benefits. And I think we have to keep this in mind, that public health is first and foremost an assault on inequalities that leave millions of people unable to deal with the costs of healthcare or the need for quality healthcare. And I think the second point that is very important is that healthcare workers must think beyond themselves. I said this at the end of the Lipa Kama tender strike, and I know it caused a bit of a tension in the room, but I said that the KMPDU must think for the country in terms of what kind of a universal health coverage system we require, what kind of a national health insurance scheme do we require, what kind of quality services do we require, and we cannot leave that to public healthcare statisticians, to theoreticians, but practitioners, people who understand what it's like to be in a surgery, what it's like to be in a hospital or a dispensary, what it's like to essentially not be able to provide quality healthcare. You must be in the driving seat of determining where budgets go, where investment is placed, because otherwise you will find that essentially we will have a system that actually only benefits a few people. The third point is this, is we have seen over the last 10 years the erosion of civic space. Often when we talk about civic space, we think about non-governmental organizations, and for many years now I have been arguing that actually non-governmental organizations, the 2,000 organizations that were referred to by the Interior Cabinet Secretary 2 days ago, they are a small micro element in a civic democratic society. The more interesting part of civic society is yourselves. It is professionals, it's occupational-based associations, it is trade unions, it is large numbers of practitioners who are taking action that have an impact on millions of people. And we have to recognize that over the last 10 years, civic associations, professional-based associations, trade unions have been pummeled, they have been throttled, and they have been divided by not just the state, by those of us who don't understand the power of unity and the power of collective action. And as we go into the next cycle of governance, and I'm talking really about not even August the 10th, I'm talking about October and November and 2023, we will have to protect this space very carefully. And what does that require in many ways? I think it requires two things, and I'm coming to the end of this presentation. The first is that we have to think about alternatives to the strike. We can romanticize the strike. It is an essential tool of collective bargaining, but we have to have other tools to be able to make the changes that we require. We need to think about how we use our moral pressure. We need to think about alliances with legal professions so that the costs of legal action are not too cumbersome for our associations. Perhaps we have to think about these new ideas around work councils. And most importantly, we have to think about what is going to happen to our unions in the context of a greater digitalization and a greater atomization of the workplace. Now, it may not look like it's coming very fast for the health workers, but I can predict that in the next 10 years, as we look back at this period, we will realize that actually the space for organizing has actually shrunk as a result of technology, rather than expanded as a result of the digital technologies that are there. So I think we have to invest as a set of civic actors on how we wish to use technology and communication technology particularly to be able to organize, to be able to keep people connected, and to be able to democratically make decisions. Because as we know, simply by looking at Twitter or any of these social media giants, the capacity for cacophony, for a lack of coherence, is now very high. And for many of you who are shop stewards, many of you who are leaders, one of the preoccupations is how do you keep the base under you, and how do you get a clear mandate from that base to be able to prosecute a particular position or not. So I think we have to embrace new technologies and work with them. Let me end now with a couple of ideas that perhaps would be important in this electoral season. With the Kenya Medical Practitioners, Dentists and Union, we have been talking about 5 ideas that really should be the basis of all political aspirants and political parties. And I'll run through them extremely quickly because I think my time has come to an end. The first is that we must essentially ensure that there is a community health worker for every 50 households in this country. So whatever it takes, whatever resourcing it requires, we need to make sure that that is the case. The second is that we have to increase investment in public health care going into the next cycle. So if we are not engaged in the medium-term expenditure framework as unions, as associations, then we are essentially dooming the next 5 years of our capacity to be able to get good quality health care. The third one is this. For too long, the National Health Insurance Fund has been draining into private healthcare facilities. And I'm talking primarily not about, private missionary or religious institutions. I'm talking about those very big guzzlers, the SUVs of our nation, the private healthcare facilities that chew upwards of about 60 to 70% of the National Health Insurance Fund. This is the time to cap investment from the National Health Insurance Fund to 15%. Let us go out, push our aspirants to start articulating this and our political parties. Fourthly, let every county have a level 4 hospital. Let this be one of the clarion calls of all of us as we go into this process. And the very last one is, can we all press for prosecutions of the thieves that come to our public health care facilities? Some of them are doctors, some of them are nurses, many of them are civil servants. But let us try and get that cost of corruption to be so high that we do not see corruption pursuing our patients the way it has for the last 10 years. I'm going to stop there and thank you all. Hope that I've generated some conversations and that we come out of this session with some alternatives to the strike, but that we do not also demonize the strike, because as I started by saying, it is the strike that has generated the attention that we've seen change public health care and the conditions of your workers. Let me end by just saying I salute you. I honor you for the work that you have done over this last period. If this is the first meeting I've been with health workers and not had to wear a mask, it is because of you and the work that you have done to keep down infections, to treat the afflicted, and to essentially to put this virus almost behind us. Thank you very much for the time that you've given me to speak to you today.
Thank you, Irungu. Thank you. We can clap for him again. Just to know whether Isaac is around. Isaac. Just to know whether Dr. Peter Kamunyu is around. All right, so looks like we'll have Isaac present, then we'll have 1 or 2 questions to the presenters, and then I would like to ask Bart to prepare for the next panel discussion, and I hope Peterson, you are there, Morris or Petu, so that we can be able to get on to the next. and Tom. All right. So let's welcome Isaac, who will be presenting to us about strategies for averting industrial actions in Kenya. Please, can we have the slides for Isaac? 10 minutes.
Okay, 10. Okay, thank you. Thank you, Chair. Sorry, I was outside the tent when you called us out last time. Okay, I know I am the last speaker for the evening, and I know people are also thinking about traveling in Nairobi. I'll take 10 minutes and we'll be off for a discussion. My name is Isaac Ntwiga. I work at NHIF Health Africa in Kenya, and I'm happy to be here. And this is a very good conversation. It's a very good meeting where health workers are actually meeting, and more so not meeting in the streets. Meeting, we could call these peace times, when people are able to converse and talk to each other. And I want to continue with my presentation as we go to the next slide from where the last presenter left. And I just want to share a case of Turkana County. And it's something that has happened, something that is still happening. Probably we could learn something from it as we think of alternative dispute resolution mechanisms that we hope to employ and deploy to make sure that we are a vibrant, listened to, motivated, and very well developed health worker, for the next decade. Next slide. Okay, next slide. I've said this. I want to share this. And why I want to share this is that we know we've just come out of an era of very long strikes. Though I remember when I was a younger health worker, we had one which lasted a year. For those that are older in the room might remember, 12 months plus in this country. We've not gotten there yet, and we don't want to go there. We want to make sure that we are delivering and we are listened to as health workers. As we know, labor relations in this country are entrenched in laws. They are not things that are produced in boardrooms. They are not things that people think about and then they just say, let's go relate. We don't have a shortage of regulations. We don't have a shortage of ideas, as a country on how we need to relate, whether it's in the public sector, whether it's in the private sector, whether it's in the faith-based sector. Whatever sector we are in, I think there are lots of ideas in the archives on how we need to do this. Next slide. Now, in Turkana, if you can see that picture and see it well, I'm happy that that picture photo has a lot of ladies. We've heard in the morning about gender integration, gender mainstreaming, being gender sensitive and so on. This is a team of our colleagues, your colleagues, the chairmen who are here, the secretary generals who are here, the CEOs of unions who are here. These are colleagues from various unions seated and standing on the same photo, just like we are seated in the same tent today. And this is Turkana County a couple of years back. And with them, you see, they have the CEC for health. They have the director for medical services. He's there, Dr. Gilchrist. And all the unions are there. And this photo actually is the reason why, even when we had the longest strike, most recent health workers strike in the country, it didn't happen in Turkana. Tunakumbuka hivyo? Do we remember that? Do we remember that? Hello? This photo is the reason for that. And probably it's something that we could borrow moving forward, because we've seen the county benefit from that session. We've seen health workers benefit from that session. We've seen the Akiru and the Ekiru in Turkana County benefit from undisrupted service delivery because of that session. Next. This is a sample process of negotiating a labor agreement, and I suspect Mathew might have spoken about this while I was away, borrowed from Rice University in Houston, Texas. This document, this graphic, this small, graphic you can see in front of us, has actually seen itself in our documents, in our laws, in our guidelines, in form of text or in form of something else. And it says, as we negotiate, everybody has to prepare. The employer has to prepare, the union has to prepare. It ends up with the management from the employer approving whatever was bargained, and a vote from the unions, and then the unions will either agree with it and we'll have a strike, or we resume bargaining again, or it will be ratified and we'll live in peace, knowing that everybody is happy with the resolution. Next slide. Now, in Turkana County, which I'm sharing with us today, you need to see what is happening in Turkana. Before devolution, when they took stock of the health workforce in Turkana County, and they looked at what they inherited from the national government after devolution, they had barely 350 health workers, actually 327. The entire county, with about 250 health facilities in an area of about 77,000 square kilometers. That's from Kitale to Thika. If I can put it in perspective for you, from Kitale to Thika, that's the size of that county. Over the time, that county has increased health workforce to about 1,279. If Bimji was here, I would tell him, when I worked in Turkana those days of 300s, there were only 3 doctors, and all of them were MOHs, so nobody was there to do a cesarean section. Today, if he goes there, he has a membership of more than 70 for KMPDU in that county, from 3. Yet, that only accounts for about 11%, or we would say they are only at, we said our average is about 13. They are not yet a half of what we are talking about, 23. They are not even at 12 yet per 10,000 population. But you see how the county has grown. So, as much as we would want to say nothing has happened, at least in terms of quantity, let me not talk about quality today. In terms of quantity of the workforce, people are there. Nurses are there, doctors are there, clinic officers are there, and so on and so forth. Indeed, they are even paying a small stipend to over 1,900 community health workers in that county. Let's continue. So, in Turkana, because of this issue of people agitating, wanting to go on strike, threatening, go-slows and everything, working together with them, and we were there as AMREF. AMREF has been working in Turkana for over 55 years. We thought we could trigger a conversation. And everybody started knowing about who is here. And what are they doing? By the way, you could be a unionist in Nairobi, but a county government somewhere might not be knowing whether you have members in their county. Let me tell you, it's possible. Ni sawa sawa? It's not enough to just be in Nairobi. You could be your members could be in a county where the employer doesn't know whether they have a union. We discovered there is entrenched mistrust between management and the health worker unions, that whenever they meet, it's about you against you versus me, or from the outset you won't accept what I tell you. Are you getting that? Then there was lack of industrial relations, no leadership, capacity to lead that. It's not enough to be a director for health. It's not enough to be a chairman of the nursing union in a county. You need more than just that. You need to have the capacity to actually do the job that you're given. And in this case, industrial relations, negotiation skills was not one of the strengths. And all of them could attest to that. The CHMT did not know how to relate with the health worker unions. The health worker unions did not know how to relate with the county government. Hata tujatoka kwa county government kwenda to the employer, the county public service board. We are talking about actually colleagues who are managing each other and they don't know how to relate from various levels. And then lack of communication led to mistrust, led to people not knowing what has been decided. Nobody knew what was happening. And because of that, going on strike, would be something very easy. Next slide. So after mapping out all the health worker unions and their leadership, there was a shuttle diplomacy, talking to one, not talking to all, talking to one by one. This is an art known very well by politicians, especially this season in this country. Sini sawa sawa, hata kama wengine wanasema wakumbuki ile kitu walisign ilikuwa na nini ndani. But it's okay. We should not be union leaders of that kind. Then issues were mapped. What are the issues? What are your biggest complaints? Both the employer said, these are my problems with my employees, and the employees through their unions stated their problems with the employer. And then a meeting was held, a working formula was done, people represented each other, all unions, there were 8 unions, CHMT, Labor Office, and they established what is called a round table forum. This forum was established to forestall people going on strike. Are we together? That was the only honest agenda for this forum. Let's come talk to each other, let's address our issues. That's when people realized, yes, indeed when people say we have never been promoted, it's true. Although also some have been promoted, but they never said. Because also when we go on strike, see, where if an increment is done, so we all benefit. And so on and so forth. So all these issues were laid bare and everybody was looking at the same problem. Next slide. It was a meeting of equals, no victimization. There was faith in each other. And then, after that, it became a quarterly meeting. I don't know whether there is anybody from Turkana here. Okay. Quarterly meeting. So that, rather than waiting to agitate until problems are over and we issue a strike notice, we address our problems in the quarterly forum. When my brother was talking about work councils and those kind of, ideas and many others, so they meet quarterly and they say, hey, we are having this problem. And if we don't address it in the next so months, I think we might want to issue a strike notice. Then the employer also says, I also have issues with you. Your members are not coming to work. Are you getting that? I will do that, but also improve on people coming to work, improve on absenteeism, and so on and so forth. And they said, industrial action will be the last resort. So the results, the Turkana County Health Sector Roundtable Forum was established. They have co-chairs from the unions and the members, and the person who is like the go-between for them is the county labor office, and they sit every quarter and ask, by the way, what did we agree on last quarter? Where is the progress? Where is the bottleneck? Is there anything we can do together? So rather than now going to the streets, people go to the boardroom, they talk, they agree. As I've said, as a result, they never participated in the nationwide strike, so continuity of services in that county went on. Health worker promotions, salary payments, and supervision was done on time, including regularization of people who are having funny-looking kind of contracts, job grades and everything. We know it's not done 100%, but when the unionists in Turkana look at it, they say, this is good progress. If it has been done for 80% of us, the next 20 is coming. And this goes on and goes on. And then there is that quarterly feedback. On their part, what they give back is service delivery by also asking their members to tell them, if I'm going to go to that quarterly meeting, let me not go to deal with absenteeism issues. I'm trying to argue about your promotion and you're not at your post. I'm trying to argue about something that needs to be done for your facility, workplace improvement, yet you are never there. So absenteeism has dropped. Actually, I believe with an ongoing assessment which is there, Turkana will be below the national average of 25%, where we say 25% of health workers every day in this country are not at work. They are somewhere doing something. Sinisawa. So lessons learned is that our chronic industrial actions through strikes, there can be industrial action, not necessarily through strike, but through strike can actually be addressed by having this kind of a forum where we are saying we are talking to one another. It is structured. We hold each other to account. As we come to do the quarterly performance review, we also look at our, HRH, our HR issues, our labor issues, and we also measure how have we progressed in terms of working on the issues we raised last quarter. Industrial sometimes capacity and making sure people look like they like carrying placards is triggered by poor communication flow. When I don't know what my employer is doing, I become suspicious. And also when my employer is not know what we are up to, they also become suspicious. They hold information. So this can be done. I can see my time is up. So is there a way, the question for this forum, for all of us moving forward, is there a way we could have this, dispute resolution mechanism institutionalized so that it is a modus operandi for us, in the country, and we'll see that we're able to move forward unit by unit. And that way, we are going to sort out HRH issues, whether they are numbers or the quality or workplace issues or performance issues. And that way, then we are going to be sure that the critical ingredient required for UHC, which is HRH, is actually available, is motivated, is ready, and is actually functioning optimally. And as a country, then we are going to realize primary health care and universal health coverage. Thank you very much.
Thank you, Isaac. Can I have a seat? Please, let's clap for him. I think this forum is really for us to learn practical examples. How can we make the workplace better, and how can we be satisfied? And because I know each and every one of us wakes up to work and to help that patient, and you want to go home feeling satisfied because of the work that you have done. We come to the end of our presentations today. What now want the body? I can't see him. Please. So we're going to the panel discussion. Peterson, where are you? Can't. So this time we will take about 40 minutes, please, for this panel discussion. Take off.
Thank you. Irungu, good to see you. It's been a while. Thank you so much. So this is the last session, and I'm not intending also to be here want to keep you for a while. We are supposed to be actually winding up at 5 o'clock, but of course we know how also time today has slipped from our hands, and so we're trying to play catch up. So as we look to discussing this particular issue at hand, which is understanding the role of social health insurance in universal health coverage. Before we do that, we can probably stand up. Remember our exercise? Yeah? Remember the earlier exercise we had in the morning or in the afternoon? So we can do that again to just rejig ourselves and refresh ourselves a bit. Right, where is your kidole? Yeah, this electioneering period is good to identify where you are. Yeah, kidole moja, where are you? Good. So remember what we do? Yeah? Housing your neighbor's index finger so that we have a sort of a jigsaw. Not really a jigsaw, but sort of a zigzag. You house it like that. Good. And then at my count, you try and grab that particular index finger. Okay? So this is just calling it to be very agile, attentive. Yeah? Just be in the room as activities is going on. So moving forward, of course, you need to be very attentive. So are you ready? Are you ready? Okay, we do a dummy run for our guests who are joining us so that they can catch up as well. Then we do the action. The actual one. Okay, on my count. 1. Are you ready? 2. Not yet. 3, grab a finger. A dummy run. Let's do now the real one. On my count. Are you ready? 1, 2. Grab a finger. You can redeem yourself. The last one. I'm giving you. Redeem yourself. If you're not active. This is it. Yeah, if you fail the 2, this is the last one. How good are you? How agile? How nimble? Let's see. On my count. 1, 2. Grab the finger. Fantastic. Clap for yourselves. Good. Let's have a seat and have a conversation. As we're winding up right now. This is a big topic, we know. And insurance has become very critical. And if anything, the COVID-19 has made us realize that as much as we have our national army, the KDF, critical is insurance when it comes to fighting pandemic. Because you don't know how that pandemic will stretch you. And we've seen many families exhausting their resources, going back to NHIF, and even exhausting the NHIF. COVID and containing COVID became very expensive. And you can attest to that fact. Many families were really affected when they were in the ICUs. And people were questioning, how come that we're being charged exorbitantly, close to 1.5 million, close to 2 million shillings if you have your patient in ICU. And you look at what they're charging you, the most expensive item there was a PPE, wasn't it? And people were questioning, how come when this doctor is checking in, he's wearing the same PPE, he'll go to the same another patient with the same PPE, and still they'll charge the same amount. But it's bringing the critical question of insurance. And this is where we want to buckle down and discuss. As you've heard, we've just only 40 minutes. Let's just make it 30, so that at least we can give you more time also to ask questions as well. And in the panel with me, I'll just give an opportunity to everyone to introduce themselves. I can see we're being joined by Dr. Mathew Thuku. Thank you for joining us. So we'll gravitate the discussion away from industrial action to NHIF as well. We have as well Isaac Ntwiga from AMREF Kenya. We have also Irungu Houghton, who is Executive Director of Amnesty International. We have as well Peter with us, who is our host. So thank you for joining us as well. And I'll give the gentleman with the mic there to introduce himself, so that we can continue as well. And each of you also to just also have introductory remarks. You can long press it. Long press it.
Okay, good afternoon. I'm Maurice Odhiambo Petu, the Deputy General Secretary, Kenya National Union of Nurses. Thank you.
Fantastic, fantastic. Thank you so much. All right, and we had of each and every one of you introducing yourselves as well, but I just wanted us to predicate our thoughts on NHIF and understanding the role of social health insurance in the universal health coverage, which is a big component of the Big Four agenda of President Uhuru Kenyatta. And I'll begin with you, Dr. Mathew Thuku, on that particular note. Looking at where we are currently, and especially on the legislative basis, we know right now NHIF is mandatory. and people are saying it is people in the informal sector who are being targeted. What about people in the formal sector? What about the informal sector? But just as an introductory remark, do you think NHIF has served its purpose in this country the way it should?
Thank you very much for that question. I think for NHIF, it has been a gradual process in terms of trying to address the insurance needs of Kenyans. And for a long time, the people in the formal sector have been bearing the brunt of the insurance in terms of meeting the cost of NHIF. And there has been advocacy for those in the informal sector to pay a minimum amount. I think per year has been around 600 shillings. But that has not been enforced to a level where the numbers would match the demand. So the supplementation has mainly been within the formal sector. And recently, there has been an increase, still targeting the formal sector. I don't know how the regulations are going to ensure that the informal sector is also reached to be able to actually ensure that the kit is wide enough to be able to cover the needs of the Kenyans as far as healthcare insurance is concerned.
Right, so let's hear from Irungu Houghton. 500 shillings a month. Some may say this is a tidy sum that many Kenyans cannot really afford. At the end of the day, 6,000 shillings. Do you think, from your own assessment, also that is a very high amount and it should be mandatory?
No, I think as Amnesty International, we think that the macro model that underpins NHIF is actually flawed. So the problem is that at a much higher level. Creating a national health insurance program or fund that is reliant on contributions of people who need the services is suboptimal. And that actually what we should be looking at is a national insurance fund that is primarily funded through a tax-based system that ensures that those people who need the services most are not being the ones who are being asked to pay for it most, right, or to pay for it. So in some ways, I think for us, what we would be arguing is that we need to see the new political party formations beginning to look at a different tax system that would ensure that NHIF is fully funded. And there could be a contributory scheme. But I think to rely on contributions from a population that I think we're being told is something like 40%, above 40% below the poverty line, which is where most of the illnesses lie, is actually a flawed model. So we would argue, don't go down that route. The second one is really that we have seen the national insurance, the gains of a limited national insurance scheme being essentially enjoyed primarily by for-profit private institutions rather than our public institutions. So we have to support those counties that are beginning to argue that their civil servants will only be treated in public institutions. And of course, there is a short-term risk with this because we know the quality of the public healthcare system at the moment. But the reality is that unless we invest, we are never going to have a public healthcare system that can take care of people.
And Matthew, when we had, of course, the height of COVID-19 and people were saying we can introduce, this is Ntwiga, sorry, we can introduce the NHIF by then. You go to the counter there, they tell you we're only serving civil servants, right? Even if you have that particular insurance, they cannot be served at the end of the day because it was predicated and reserved for the civil servants. And many failed to understand what was the rhyme and reason for that. I don't know if you experienced that or someone near or remotely connected to you experienced such an eventuality?
Yeah, I think for those of us who have been in this country, we'll know that we've been talking about NHIF reforms for a while.
Yes.
And I think it started in earnest around 2010. And what you're raising was actually one of the first initial, reform agendas to have a scheme within NHIF for civil service. And since this was under a very big employer, which is the government, and the government was able to pay, then as a provider, I would want to serve that client, because it means when time comes for the premiums, for the reimbursements to be paid, I'm paid by one entity which I'm sure will actually pay, and this is the government. But that has its own downturns, whereby now everybody else, the message that was received out there in the communities was that, oh, NHIF is government, it's now serving public servants, so this is almost like a scheme for government. And in some instances, I remember I could go into a training hall and find very educated professionals and ask, who is insured here, who has a medical insurance cover, and nobody raises their hand. Then I say, could you check your wallet? Do you have the small blue NHIF card? They say, yes. In fact, last week I was checking if it is updated. Then I'm like, but what do you think it is? Do you consider that medical cover? So perception out there, NHIF is not still considered insurance by many of us, even those that are very well educated. If that is the case, you can imagine now what that means for that other person who thinks that insurance must be some lucrative medical cover provider with a nice fancy name out there providing cover. So we have to change that. And then the other floor, the second floor, which I believe and hope this second wave of reform with the bill and all the ongoing reform after the second phase of UHC launch happened, is we have to make sure that it is not hospital, it is health. Because now we made it a national hospital insurance fund. It should be a health insurance fund, because it implies that for me to benefit from insurance, I have actually to fall sick, then go to a hospital. So if I'm doing whatever I do, whether I'm taking whatever I'm taking out in the village and I'm not falling sick, why do you want me to get insurance? Yet you have clearly indicated that it is supposed to be a hospital fund. I have no intention of going to the hospital, so I have no intention of joining that bandwagon of NHIF. So that messaging has to change so that it's about health, and my health is beyond going to the hospital. It actually starts in my home, in my garden, in my kitchen, in my neighborhood. That's where it starts. So it has to be about that for it to gather that traction and make sure that people are looking for it, and it is not the insurance looking for them. And that is the only way then you'll say we are able to finance our own health care. Because as much as we'll say it will be free, it won't be free. There's nothing like a free lunch. Somebody somewhere will pay for it. So as that somebody readies themselves to pay for it, then they need to understand what it is about. It's about their health. It's not about the hospital. Thank you.
Thank you. And I think even on the name bit, as you say, it's about the health and not the hospital. Part of the reforms that we know Peter Kamunya will have talked about is changing the name, and I think also that is in the works right now. Let me just go to Matthew and ask that when we look at another eventuality that will be affecting the populace is the fact that chronic diseases right now will not be in the private hospitals, will not be attended to by NHIF, and have been very categorical on that. And this also has raised hesitation amongst the citizens, saying why. And we know how overburdened, when we look at our county hospitals, dispensaries, referral hospitals, they're overburdened. Do you think this is a right move from NHIF? I know you're not holding brief for them, but at least you, as a union member, what will be your take?
Okay, thank you, Ainea. I think the move is ill thought. Because first, before we talk about the many reforms that NHIF as a structure wants to introduce, we need, as the consumers, as the health service providers, to look at a few things. One, who is managing the fund that is being contributed today? How is it used? And is it worth the services that we get from our institutions? So that when we have to reform and even increase the contributions and bring in more contributors, who most of them it is the formal group or the formal employees who are still paying for those informal contributors. So we really need to look at the value of services against the contributions that we are doing presently. As health workers and contributors, we know that most of us go to public hospitals, and the funds that are being pulled into NHIF, bigger portion of it goes to private hospitals, which is not accessed by the common person who, because of their living environments, go to the hospitals very oftenly. So we need to restructure, one, the ownership of the management of NHIF, so that if it is the workers' funds, then the workers must be involved in the management to be the directors and the trustees, so that we monitor how our funds are being used before we introduce any other thing. Two, the NHIF in itself cannot be the managers of the funds. They cannot be the same people who collect the funds, and they cannot be the same people who sometimes use the funds. Because if you go into how much they are using on their own employees, you will wonder. So I think we need a lot of transformation before we introduce the others to contribute. Now, the coverage that is being done by the fund is just so poor, because you'll get that most of the people who frequent the hospitals are people who are living with long-term conditions. And if this cannot be catered for by NHIF, then most of our people in the community are going to die without getting the services. Therefore, there is a lot to be looked at on the coverage. Remember, most of our health workers died helplessly because they could not afford the high cost of COVID treatment, which was not being covered by NHIF, which is the only fund that covers the health of health workers. Therefore, we had huge hospital bills arising out of COVID patients who are health workers. We had to do harambes to bail out our colleagues. We had even to do harambes for hospital bills and funerals for our colleagues. So a lot must be done with NHIF reforms. We must be involved as first the service providers and at the same time service users. Thank you.
Thank you. A very valid point that you raise. Before I go to Peterson, I'm given to understand also we have members from NHIF. Will be good to have them on the panel so that we get their input. Instead of us criticizing them, they will be here also to tell us more and add more, of course, information and broaden our understanding as well. Right, where are you? Oh, karibu sana. I'll just give up my seat for you so that we can continue. Oh, Irungu Houghton is being a gentleman. And I know Irungu is very particular when it comes to gender balance. Yeah, most of the times he's refused actually and declined to come to the shows because he tells me, oh, you're just a manel. I cannot be in attendance. You need a woman in that particular panel. So I salute you for that and I respect. Good. So before even, let me just finish up with Peterson, then we come back to you. Because Peterson, when we look at this constituent that we call the informal sector, I think it's a high time that we should critically consider the informal sector. We have, in our minds, we always think about the chuokali, artisans, this is the informal sector, so we should not really go after them. But if you look critically, and if you go even to the shops in town, you'll find most of them, they don't even have ETRs, and they're Asians. And most of them, if you want to, they don't even have the pay bill number. Or they buy goods. They'll tell you, no. You want to pay via M-Pesa? Use this number. Why do they do that? Have you ever questioned? And even sometimes when you purchase anything, they're not quick off the mark to give you the receipt, unless you ask for the receipt. And this is the informal sector that we are talking about, because most of them are not remitting their taxes. And this is where we need to broaden the net and ask, who is the informal sector? So, as a union, and we are trying to push, and the NHIF will tell us who are the informal sector. Maybe it will be good to know. And I like what Mathew has said. Are you participating holistically to these reforms that NHIF is coming up with? When they talk about public participation, where is the stake of the union as well?
Yeah, thank you, Dibal. And thank you for that question. And I think I want to associate myself with the most of what has been discussed on this panel. And let me start by saying that NHIF is a good thing. I think we must start there. Number two, we must say that factually, NHIF is guided by certain laws and policies. And I think as a union, especially the reforms on the law, we actually do support that. It was a very progressive law, and even including everyone. You see, you cannot be said to guarantee every Kenyan health if then you don't have a way of funding that health care. And what I understood, because we participated and we supported some of those reforms, is that it's trying to extend its coverage, and especially in terms of resource mobilization, by going to the informal sector. If you pay tax, then you can be followed, and you can actually be able to pay NHIF for anybody who employs anyone, and even those who do not employ, those in self-employment, and probably it's only yourself. Then from the benefits that you get from NHIF, you should actually be able, and I think we also agree with the government, because sometimes when you tell people that it's optional, as it had been, then it becomes difficult. But then when these people may require some of the services, then it's us Kenyans who will then come to try and contribute, and sometimes it's not enough. But I know the next question that will come up is, what about the quality? And when now we talk about the quality that you get, there is part of the NHIF, because I know the super cover, that is 500, we can say in some aspect it's actually deficient, and actually most of the hospitals refuse it, unless you're being admitted. For us who enjoy the civil servants, it's actually comprehensive. Like myself, I enjoy the same. I don't have another cover, and it has actually been sufficient for myself. And what I'm trying to say is that we should not only look at and castigate NHIF. What about the role of the employer? The Employment Act of Kenya, Section 34, mandates every employer to provide sufficient health coverage for their employees. Now, what has happened, why I enjoy a comprehensive cover, is because I pay myself, because actually what we pay is from the employee themselves. But then the ministry pays for me what is above, so that I can enjoy that comprehensive cover. And this is the problem we have actually had with employees under the county governments, because they do not top up that amount so that they can get the comprehensive cover. So I'm not trying to say that there are no shortfalls in NHIF. We should be able to look at this super cover. If then we are bringing more money into this, into NHIF, and if also the government is going to pay for anybody who cannot be able to pay for themselves, meaning that basically every Kenyan will be contributing to NHIF, then you must be able to guarantee every Kenyan that when they go to NHIF, they'll be able to get that service. And how do you do that? I think our proposal has always been, this money Because the country cannot rely on what we are getting from NHIF only to fund universal health coverage. We must be able to use probably part of what we get in the NHIF to capacity build our hospitals. Because even the questions that people are asking now, when you take us there and you want us to go for chronic disease services in the public hospitals, what is the capacity of those hospitals? Do they have the equipment? Do they have the skilled personnel who are able to take care of those people? Can they manage the numbers? And the answer is, to say the truth, our public hospitals cannot be able to handle that burden as we talk. So what comes first? We must first build the capacity. And we can build the capacity by NHIF itself capacity building, but then the bigger part is on the government of Kenya, because I think it's even in the constitution that they're supposed to offer capacity building. It's their mandate within the constitution in the health sector. And only then after we have done the capacity building, can we then see that for us not to be able to utilize so much in the private sector, that this category of people can be seen, can only be seen now in the public sector. But for us to say now that chronic diseases, all of them have to be managed in the public sector, then we will be making our people suffer. And I think that is, I know there are some sessions which has been held on public participation on the same. And I think the position we have held as the union is that that is a good move, but at the wrong time. Let us first capacity build the public facilities that we do have. And after we do that, then when we are comfortable, we can go back and give a nod and say, now let us bring people to the to the public facilities, so that then we can capacity build them and we can actually offload them of the catastrophic cost they suffer when going to the private facilities. Yes.
Right, thank you very much. And I think also our gracious lady will just introduce herself, and you tell us more about, first as an introductory just remarks about energy.